Thanks very much, David, for that introduction, and thanks for the chance to make some opening remarks at this meeting. In thinking about what I might say today, I quickly dismissed the idea of reciting the standard statistics on globalization, urbanization, and infectious diseases, because many of you know what those statistics are, and in any case, I think they'll come out frequently during the course of this meeting. So what I propose to do instead for 20 minutes is to put a different question, and that is, in this era of sustainable development, what could the Sustainable Development Goals contribute to the theme that we're interested in this meeting, microbial threats in an urban environment? Now, the Sustainable Development Goals have been out there for a couple of years, and they have generated a diversity of responses from a guiding light for development to worse than useless. And both of those views, for all I know, are held within this room. I'm going to give you my opinion about that, which is that the SDGs could indeed be a guiding light for development, but with one important proviso, and that is that we treat the 2030 agenda not as a blueprint for development, but as a set of testable ideas. In other words, the 2030 agenda is an agenda for research. Now, the term paradigm shift is seriously overused in our business, but I think it's actually merited on this occasion in making the transition from the Millennium Development Goals to the Sustainable Development Goals. There really has been a shift in thinking. The MDGs, which finished in 2015, were really about setting priorities for principal causes of death among women, children, and from communicable diseases in low-income countries, and focusing programs on that problem. The Sustainable Development Agenda is very different. It says, let's think about what it really means to build health systems and make those systems more effective. And the kind of health systems that we're talking about are not just those that are concerned with public health and providing medical and clinical services in the traditional way. They're health systems that bring together health with agriculture, education, transport, energy, industry, and all the rest of it. So what we need is a much broader view of health systems. If we take that broader view, I think we can be successful. I think we can generate new ideas, and I think we can be more successful in advancing health. Now, there's a lot of detail around the Sustainable Development Goals, and many people have disliked the amount of detail. This is one portrayal. This is my portrayal of the detail around the 17 goals. I put health in the middle there, and the other 16 around the outside. And the purpose of that is to signify that health both depends on the other goals and is a contributor to those other goals. Now, in the context of this meeting, if we wanted to look at the relationship between health and the urban environment, the natural thing to do would be to look at the relationship between Goal 3 and Goal 11, which explicitly deals with the urban environment. But in my view, that would be far too narrow a perspective, because a lot of what goes on in the urban environment depends on many of the other goals. For example, those to do with poverty, education, equity, industry, and so forth. You could go all the way around the map and determine that the theme we're interested in at this meeting is broadly determined by many of those Sustainable Development Goals. So how do we make the links between health and those other Sustainable Development Goals? And why do I think that that might be effective? Just to indicate, before I say a little bit more about that, about the shift in thinking, I think it's rather nicely represented between the difference between the left-hand and the right-hand side of this picture. On the left-hand side is a focus on burden of disease, top causes of death around the world. And there have been many, many lists of these, and we in WHO have generated them too. And that has been our focus for activity. Where you are in the world will depend on what appears in your top 5 or so, but you see here, this is a global list. Lower respiratory infections, acute respiratory infections in children are still important causes of death. But that perspective, focusing on diseases, is very different from the perspective taken by others. If you're working for UN Habitat, for example, another UN organization, and you're interested in how you develop the urban environment, I've summarized some of the findings on the right-hand side from about 5,000 separate initiatives that they've reviewed over the last 20 years or so. You can see that the priorities that come out are not organized around particular infectious diseases, as we have focused on health. They're organized around upgrading of slums, water and sanitation services, housing, urban governments, financing, and the economy. In other words, they're much more organized around the processes that are important in developing urban systems. They are less focused on specific diseases as causes of illness and death. Now, before I plunge more deeply into the SDGs, it's worth reflecting a little bit on what we learned from the era of the Millennium Development Goals. This is one of the spectacular successes over the last half-century. It's the fall in childhood mortality from the 1950s in, at the top, low-income and then middle-income and high-income countries at the bottom. And you can see that child mortality has been persistently declining. But at the right-hand end of that picture, the red line starts to slope down more deeply, more rapidly, and that signals a real convergence that we achieved in the last 15 to 20 years in accelerating the rate of decline in children in low-income countries. And that was coincident with the era of the MDGs. Now, one question that springs immediately from this is, can we do as well as that in the era of the SDGs? And in my view, that's still an open question. But another important question is, if we achieved that rate of decline, how did we actually achieve it? And there are a number of analyses of this kind which differ in detail, but they all give essentially the same result. When you look at the reasons why child mortality fell, you can attribute a proportion, maybe about half of the decline, to direct medical interventions like vaccination, like oral rehydration, like antibiotic treatment of kids. But all the rest of it is attributable to deeper causes and deeper risks, primary prevention, issues like population fertility, female participation in the population at whole, female education, environmental factors, income equality, economic development, and so on. And without those other factors, you can't possibly explain the reductions that we've seen in child mortality. And on the right-hand side of this picture, I've roughly aligned those factors with icons that are associated with the Sustainable Development Goals. And this is a strong reminder that whilst we achieved a lot in the MDG era, we relied on things that we didn't explicitly take account of at the time, such as these deep primary prevention factors. Now, for the rest of the talk, I'm going to organize my thoughts along these 7 points, because acknowledging that really what we're trying to do now is improve the development of systems for health, systems broadly conceived in the way that I described. So health systems specifically, leading to universal health coverage, that's number 2, but health working across all sectors of government, as I've also described. If we're going to achieve that, those systems need a series of characteristics, a lot more than I've listed here, but I'll just run through these ones quite quickly because they're important. They need to be affordable, equitable, measurable, testable, and sustainable. And what I'm going to tell you in the next few minutes is that we know quite a lot about how to do that, but we know by no means everything, and that's the basis for an important research agenda. Let's deal with the number 1. That's the health in all policies, intersectoral action, working across government. One of the things that we've already seen happen quite quickly, which is a continuation from the MDG era, is that the profile of health has been raised in development. So the picture I show you here was the launch of the Sustainable Development Goals at the UN at the end of 2015. The inset picture is an important picture which shows the Secretary General, Antonio Guterres, meeting with the newly elected Director General of WHO, Dr. Tedros, with Amina Mohammed, the SDG Supremo in the middle there. Now, these pictures will become increasingly common, as increasingly health matters are seen as matters for whole of government and not just matters solely for ministries of health. When they're discussed at the highest levels in the UN, they're also discussed at the highest levels of in national governments. And my experience going around the world so far has been to see more commonly health discussed in the offices of prime ministers and presidents and not simply in ministers of health. Now, there have been a number of important developments in working across sectors, and this is a personal anecdote as it related to me. The picture on the left there shows you the kind of thing I was doing about 30 years ago, which was hanging out in chicken sheds in Amazon, Brazil. And the reason I was doing that was to try and find out how leishmaniasis was being transmitted in the Amazon. And the biology was immensely stimulating, and that's a completely separate talk. The important point was that I actually stopped doing that because it was tremendously frustrating trying to turn the biology into real public health, because basically nobody's interested in leishmaniasis. That has changed substantially since this group of diseases has been brought together as neglected tropical diseases, which has raised the profile of all of them. And it's also not only raised the profile, it's also changed our views about how we might deal with these diseases. So here's two pictures on leishmaniasis. On the left-hand side, some recent developments in vaccine development, vaccine research. When I was working, there wasn't a good vaccine for dogs to prevent visceral leishmaniasis in those reservoir animals and consequently transmission to people. We now have some promising vaccines. But on the right-hand side is a picture that would appeal more to UN Habitat and should have appealed to us a long time ago. That's the environment we were working in 30 years ago. An observation that we made then was that 2 miles down the road, there was no leishmaniasis at all because people were living on the edge of towns in totally different housing. But we never contemplated that improved housing would be a solution to leishmaniasis, and indeed to other things at the time. That's the broadening of opinion, this broadening spectrum of opinion that the Sustainable Development Goals are now bringing to the fore. And this picture represents a piece of work being done by colleagues of mine in WHO who are interested in housing and protection against vector-borne diseases, particularly house design that will prevent the entrance of mosquitoes and other insects. A point about this, though, that's worth making as I show it to you is that if you're interested in disease control per se, it's very commonly the case that housing as a factor is a relatively weak risk factor. And the tendency among those who've known about this, whether we're interested in TB or vector-borne diseases like malaria, is to say, housing, that's somebody else's problem. We'll focus on the real things that we know work for malaria control, bed nets, or we know work for tuberculosis control, that is diagnosis and drug treatment. And consequently, the broader benefits of improving housing have been neglected. Now, one of the things I think we're going to need is a much better analysis of the interactions between these different goals and the possibilities for intervening against these goals. And this will appeal to some of the quantitatively minded people in the room. There have been a number of attempts to do this, but I think that they all need greater effort and greater funding to succeed. This is one quite nice study I like, done by the International Council for Science, based in Paris, in liaison with various other groups. What they have done is what I suggested we might do at the start, which is if we're interested in diseases in the urban environment, look at the relationship between SDG 3 and SDG 11, and that's useful up to a point. This particular study is interesting because it's at least semi-quantitative, but I think we need to go deeper and into further detail if we're to really identify where are the connections that we can make use of in devising better control programs. A few years ago, we attempted to do this in much more detail for tuberculosis. And what I'm showing you here is not so much a vicious circle, but a vicious triangle. We made the observation, we started with the observation that on tuberculosis, undernutrition, if you start at the bottom left-hand corner of this triangle, undernutrition is a risk factor for TB, but overnutrition is also a risk factor for TB via the onset of diabetes. And both of those factors are affected by aging, urbanization, and other potential cofactors. What we tried to do is to look at all the interacting factors to see which ones were likely to be most important. And the conclusion that we reached is that it wasn't particularly diabetes per se or particularly nutrition per se, but rather demographic factors that were most important drivers of tuberculosis in populations in India and Korea. Now let me move to the others. I've spent a little bit of time on intersectoral and cross-government action. I'll deal with the others relatively quickly. Universal health coverage. This is Dr. Tedros, the recently elected Director General of WHO. He's made universal health coverage a priority. The discussion around universal health coverage is often an economic discussion, and I've indicated one of the statistics at the top of this slide, a statistic that has been used in the release of our latest UHC report in Japan today. It's about how much people spend in order to pay for health services, which risks pushing them into poverty. But at bottom right-hand side, I want you to notice also that Tedros is making the case that universal health coverage is a matter of equity. So it's a matter of both economics and equity, and I'll make a couple of extra remarks about each of those. Universal health coverage has been described as the affordable dream by no lesser authority than Amartya Sen. But with all due respect to Amartya Sen, the dream is somewhat affordable, but affording it is going to be clearly difficult under a number of circumstances. And the statistics that we publish from WHO, two of them at least, are underneath this picture. On the left-hand side, public expenditure as a fraction of GDP on health has been rising, but rising very slowly. On the right-hand side, out-of-pocket expenditure, the thing that drives people into poverty, has been falling, but falling very slowly. The question is are these slow trends what we can continue to expect, or can we come up with mechanisms which could really bend these curves upwards or downwards, as the case may be? The equity issue is, I think, also challenging. As I was preparing for this talk, the inquest opened on Monday this week into the Grenfell fire disaster in central London. And this is a picture you probably heard about in the news, even if you don't spend any time in the UK. This tower caught flames, was burnt out within a matter of hours, and 80 people also lost their lives. The colours overlaying this map are the colours of income in that part of London. This is a borough of London that has some of the poorest people in the country and some of the richest people in the country living alongside each other. And that matter of equity has been an important matter in debating why that was allowed to happen under those circumstances. And here we're talking about one of the richest capital cities in the world. We're not talking about poor countries here. What I've also done in this picture is overlaid a map drawn by Charles Booth in 1900, actually of the same part of London in which he divided different streets into richer and poorer. And basically the patterns of rich and poor are essentially the same as they was more than 100 years ago. Now, we have made some progress, clearly, but it just illustrates that the challenge of equity is really a tough one to crack. And I think Charles Booth would be very disappointed if he saw where we now stand. There are other dilemmas with urbanization too. This is a picture that I drew a few years ago. It indicates that in the urban environment, for the poorest people, things are often better, but they're more different than they are from rich people. So on the left-hand side is infant mortality in urban environments on the horizontal axis, rural on the vertical axis. And you can see for many, many settlements with these paired observations, many countries around the world, essentially mortality is higher in the rural environment than the urban environment. On the right-hand side, though, is another interesting phenomenon. There I've plotted the ratio of mortality rates between richest and poorest. And you can see, again, that the points lie roughly, mostly above the line. In other words, in urban areas, poorer people do better, but the difference between poor and rich people is even greater. So health is better, but inequality is greater too. That is an urban dilemma we need to resolve. But finally, on the question of equity, I want to point out to you that despite all the stories that we read in the media all the time about income inequality getting worse and worse in the world, the statistics that we have suggest that health inequality is getting better and better. In other words, health is getting more even. And this picture illustrates that for a range of different health services. If you can't read it at the top, what the bars measure is the improvement in the poorest quintile versus the improvement in the richest quintile. In other words, bars pointing upwards mean that the poor are doing relatively well compared to the rich. Now, this is for a series of services: family planning, antenatal care, skilled birth attendance, immunization, and so on. But whichever set of services we look at, the inequality in health appears to be declining. The problem is it's declining too slowly. It's declining very slowly, just like the statistics on financing universal health coverage. A word about measurement. Now, to quantitative people in the audience, the main point I make here is a trivial one, which is that what we've been used to doing is summarizing national averages on statistics. And yet, clearly, we need to look at the data in a more detailed, disaggregated way if we really want to understand who it is that's being left behind in the standard phrase. So this is a series of measures of health coverage in populations. What we're really interested in is, for example, lowest quintile on the left-hand side, poorest people, worst off people in that lowest quintile, those people that are in that red circle. Who are they, first of all, and why are they in that red circle? If we're to achieve universal health coverage, we need to do a cleverer, more sophisticated analysis of these statistics in order to find out where the disadvantages really lie. There's another point I want to make very briefly about measurement, and that's how we count financing in measurement. The difficulty here is that we use national health accounts to determine how much we spend on health. And the National Health Account System is really a superb system of accounting for health around the world. But it has one big disadvantage for the Sustainable Development era, and that is we only count health spending provided health is the primary purpose. And yet, the whole point of the Sustainable Development Agenda is to look at these other areas: agriculture, education, transport, and so on, all of which have health benefits, but none of which are counted in our financing statistics. Research. I find that many audiences I speak to, I need to keep stressing the importance of research. Well, I hardly need do that in this building, a bastion of research, but I suspect you wouldn't have to walk very far from this building, and you don't have to walk very far from my office in Geneva either, before research will be questioned. The value of doing research will be questioned. Clearly, we need, as a research community, to keep stating the value of research. And as I said, I think the SDGs could be a guiding force for development, provided we treat them as testable hypotheses, testable ideas and propositions. My last point is about sustainability, and I'll make it like this with respect to the Ebola outbreak that many of us were involved in, and I know several people in this room were involved in it as well. Here's a very striking statistic about sustainability in terms of what we're willing to invest in. This was the amount of money pledged as compared with the amount of money dispersed on Ebola. Three categories: the immediate response, in other words, controlling the epidemic; recovery, in other words, investing in the systems that will prevent this in future; and research and development on the right-hand side. $9 billion were pledged in total. 6 billion were dispersed, which is an enormous amount of money. You can see that the majority of those funds were spent on the immediate response itself, in other words, containing the immediate threat. Relatively little money was spent on recovery, investing in systems to prevent that happening in future, and even less money was spent on the research and development agenda, which is clearly going to be important in future as well. Now, we wait to see whether those kinds of numbers will change, but if we're really serious about sustainability, we need to increase the spending in the right two columns on this picture. And last of all, this picture on Ebola, I rather like this. The slogan on the wall says, "Ebola stops with me," but the guy on the motorbike in the foreground is moving pretty quickly. And that was the major problem that we faced with Ebola. It arose in an unexpected place, and it moved much faster than we anticipated, much faster than we'd ever seen in places, relatively isolated places in Central Africa. We don't know where the next epidemic of this kind or pandemic is going to come from, but I suspect that we're going to be relatively unprepared for it in view of some of the statistics that I've just shown you. So to repeat my main message, the Sustainable Development Goals could be a guiding light for development, but only if we treat this as a testable hypothesis. We link research closely to the Sustainable Development Agenda. Then I think it could be transformative. If we don't do that, then I think it could be disappointing. Thanks for listening.